Today, inshallah, we will start hypokalemia. Okay. So actually, again, with the same concept by which we did hyperkalemia, because the potassium is mainly intracellular, around 98% and around 22% extra in ECF. Okay, and it is around 150 millimole equivalent per liter and around 3 to 4. Okay, so around 3.3 to 5, 3.5 to 5. I request all of you to please mute yourself. Yes. So usually whenever there will be hypokalemia, either it will be because of decreased intake, okay, increased loss, whether through kidneys or through intestines or through sweating, okay, or if there will be another, or if the patient is having any NG tube or things like that, NG aspiration can also cause hypokalemia, okay, or there is like a trans compartmental shift, okay, so it is hidden. So usually these are the reasons. So whenever you are trying to probe the reason, you can go like that. If usually intake is not a very big cause, transcompartmental shift is usually volatile, like it is depending on certain condition, like depending on alkalosis, depending on acid base status, okay, depending on stress level, okay, insulin, things like that, okay, because in stress there will be increased beta 2 increased catecholamine, so it can cause hypokalemia, okay. If there is more in insulin, it can also cause decreased potassium, okay. If there is acidosis or alkalosis, as Mozama was just telling, so there will be if there is alkalosis, there will be decreased potassium, okay. So this is the basic concept. So again somebody asked me this question related to medication. So before, I will just try to cover some medications which can cause some change in the. We discuss about succinylcholine, okay. We discuss about NSAIDs. We discussed about ACE inhibitors. We discussed about digoxin toxicity. So these are usually the drugs which can cause hyperkalemia, and diuretics, okay, things like some antipsychotics, okay, then this antifungal, amphotericin, and heroin poisoning. If patient is taking barium swallow and this laxatives, okay. So over treatment of hyperkalemia, these can all cause hypokalemia. And another thing is that even if so like these are the common things which I can just recall. So these are the common medications which can cause hypokalemia, okay. So as I told you that clinical in the clinical feature, it is related to muscles, whether it is skeletal muscle or it is cardiac muscle, okay. So in the cardiac muscle, when there will be a decrease in potassium extracellularly, there will be sort of, you can say that because the level of potassium is low in the ECF, what will be the effect on resting membrane potential, if anyone can tell? It will go up or go down? Sorry, when there is I will explain. Okay, when there is low potassium in ECF, okay, and normal like ICF is in the same, so there will be more potassium moving from ICF to ECF during repolarization. Okay, so it can cause hyperpolarization, and that is the reason for actually T wave flattening and even development of U wave. This is one of the reason. Okay, so and then more stimulus is needed to have the conduction, because the resting membrane potential is pushed down. Instead of minus 90 or minus 70, it is even further pushed down. So this is sorry, it is further down, pushed further down in less than minus 90, more negative. Okay, so this is increased stimulation for conduction. Okay, increased stimulation is needed. So there is, you can say, decrease like excitability. But there is some different effect in the conduction tissue, especially Purkinje fibers. So there is increased excitability there. So there are more chances of ectopics. Okay, so it may need to VTAC or VFib. Okay, and re-entrant tachycardias. Okay, and what do you say? So this is just a baseline, and the other muscles, it will, like for example, smooth muscles of intestines, it can cause this one ileus. Okay, so it is one of the major problem after, especially the gut surgery, to maintain the potassium levels. Okay, so in also respiratory weakness. Okay, so in the skeletal muscle, it will cause cramps, crampy condition, and weakness. Okay, so this is just an outline of potassium, and of course, when you want to correct it, either it is oral or through IV. Of course, you will not give a bolus unless some nurse mix it with dextrose water. There are, I don't think any hospital in the world will not have this incidence. Sometime 50%, 25% are mistaken as potassium chloride. So otherwise, you are giving either oral in the form of potassium chloride or potassium carbonate or potassium phosphate. These are three usually preparations. Chloride you will be giving when there is there is alkalosis, especially with when there is an increased GIT loss in the form of vomiting, okay, or diarrhea. In the vomiting, actually, sorry, in vomiting there will be alkalosis, and in the diarrhea there will be acidosis. Okay, so potassium carbonate will be preferred in case when there is acidosis, because it is alkalotic. Okay, and potassium phosphate is usually used when there is concomitant phosphate deficiency as well. Okay, so potassium chloride, potassium carbonate, and potassium phosphate. When there is vomiting, there is, unless if this it is prolonged vomiting, then also bicarb is lost. Otherwise, in few episodes of there will be more chances of alkalosis. Usually the bicarb is also lost, because usually if it is gastroenteritis, there will be concomitant board condition. In that condition, alkalosis will not occur. In that condition, acidosis will occur most probably. So, and IV, either it is through peripheral veins, it is very irritant, or through central line. Okay, so central line you can give slightly higher, up to 40 milliequivalent per liter, per hour, or maximum, and here up to 20 milliequivalent per hour, because it is irritant. Okay, so these are just basic thing. and we'll just have a look at the text. Okay. Which fruit is high in potassium? Name one fruit which actually also monkeys like too much.
Banana, sir.
Banana, sir.
Banana. Okay. So I really like, I don't know from which source this is, but it is excellent. I just downloaded it from internet, and that's why, if you are if someone is just stick to a book and never searching Google, he will never be able to find these things. And believe me, I never read it when I was a student. I couldn't get these things. So you people are so lucky that you are in the era of Google, and I have already finished studies. So I cannot get these bananas. You will never see these pictures, funny, attractive pictures in your Manhus Morgan Sharif. Okay. Anyways, so this is low hypokalemia, low potassium. Okay, less than 3.5 milliequivalent, and we will just revise it, whatever we discussed. Muscle activity and rhythmic cardiac condition, it is needed. So there will be problems in either of them. So either we are decreasing intake or extra renal through or renal or extra renal through kidneys or intestine. Yes, Dr. Sadia, you raise your hand. You want to ask something?
Yes, sir. Sir, I wanted to ask that maybe it's a silly question, but it's like I'm curious about this, that how to dig out which page is authentic or which source is authentic. I'm talking about Googling any stuff.
If you,
So
I have told this thing before as well, that first of all, if it is a review article, it will most probably it will be reliable. Number one, there is difference between research article and review article. Research article is on the base of only one research. You will find it in the form of abstract, and they will be telling you about the research. Okay. So that is a research article. So research article, you cannot rely 100%. So review article will be more reliable.
Okay.
This is one thing. So you should be trying to get a review article, number one. Number two, if you find it in one source, one answer, and then you see it in the other source, same answer, and you find it in the third source and the same answer, most probably all of them cannot lie. Okay.
Okay.
So that is the story, that sometimes there will be for example, if you find in some source answer of 15 and some source you find 16, you cannot say that it is right or it is wrong. There is minor difference. You will find minor difference. You will find different aspects being covered in different books. Like I give you an example. For example, I give you this, that when I was reading about what I was just searching today, because this topic I told you that I'm unable to teach extempore. Okay, so I was searching that in some sources they were telling QT interval prolongation, okay, in hypokalemia, and in some sources they said QU interval prolongation, because actually in true sense, if there is U wave also along with this T wave, more accurately it is QU interval rather than QT interval. So you cannot say that this is wrong. Both of them are correct. Okay. So these are minor things you will find. But for that, you need to trust, first of all. And you should keep the books away from your hand distance. Then you will be able to search. And this is just like a religious belief. And unfortunately, the people around you will just in Pakistan, what we do, ghutti, the first drop of food which we give to the child. So since then you are in strong belief that you cannot find the answer in the internet, and oh my God, the answer will be wrong. This is another thing. Okay, so I hope I answered your question. So coming back to from where we are left. So either there is decreased intake of potassium from intestines or increased loss of potassium. So as I told you, it will be through the, like, just a second. So poor intake is usually not very common. If there is any problem in intestine and then the absorption is not occurring, then it can be a cause. Okay. Alcoholics, in addition to all other nutritional problems, they will, an elderly patient who are not taking much, and also this patient with anorexia nervosa, they will also have this problem. Okay. This is what I don't know what they have written. Yes, that there is some gray clay and there is red clay. It is just like the child which are taking this dust. So gray clay is an potassium and iron binder. Okay, so it can cause hypokalemia and anemia. While the red clay will be high in potassium. This is just for making it interesting. This is nothing more than that. So red clay people will have hyperkalemia and gray clay will have hypokalemia. Okay. So as I told you, insulin, catecholamines, alkalemia. And again, the pseudo hypokalemia occurs here. So pseudo hypokalemia, just like pseudo hyperkalemia, is in error in the laboratory. If we happen to cause hemolysis, then there will be hyperkalemia. But if we happen to keep the activity of cells going on, and the sodium potassium ATPase pump are still working, so they will push all the potassium from the serum, from the plasma inside the cells, like WBCs or any other cells. So there may be hypokalemia inadvertently. So to avoid it is to immediately process it, or to keep it in a cool environment, to just keep this to avoid this pseudo hypokalemia. Okay. And there is some genetic problems in this, or some other causes. There is this periodic paralysis, in which suddenly, because of any stress or any exercise or anything, suddenly catecholamines are released and they are pushing the potassium inside, and patient is presenting with weakness. Okay, deep tendon reflexes are gone and things like that. Okay. So similarly, there is some diarrhea, VIPoma, fistulas. I was just trying to, I just had forgotten this idea. For just today, I saw this again. Diuretics and Bartter syndrome and Gittelman syndrome. Bartter syndrome is like a problem in the thick ascending limb of loop of Henle. So which diuretic acts in thick ascending limb of loop of Henle? What is that diuretic?
Furosemide.
Furosemide. So its picture is just like furosemide, and this Gittelman syndrome is at the DCT. So which diuretic acts on DCT? Thiazide.
Spironolactone.
Thiazide.
Thiazide.
Okay. Okay. So hyperaldosteronism, if there is too much aldosterone, then it will also cause hypokalemia. And one of the reason is also that when there is more aldosterone, it is absorbing too much sodium. Okay. So in the lumen, there is less sodium or less positive ion. So to maintain the electrical neutrality, potassium and hydrogen has to come out. So this is one of the reason for alkalosis and hypokalemia with hyperaldosteronism. Okay. So renovascular hypertension, this is in renal renal artery stenosis and things like that. Cushing syndrome. These are the same cause. And if for any reason there is why there will be hypokalemia and diabetic ketoacidosis?
So due to excessive insulin use?
Yes, initially it should be. I think it should not be here in this list, I suppose, because it should be related to insulin. Okay. So anyway, into the cells and the loss of intestine. Okay. So same thing occur. Cell construction, alkalemia, insulin, catecholamines, and periodic paralysis. Okay. Alkalemia, these are same they have written. Okay. Treatment of severe megaloblastic anemia. This is something new. Don't tell in the start because maybe not everyone will be aware of these things. So just don't try to have 4 or 5 answers. Just try to have the concept. Okay. Anemia and potassium is minor, but does occur in both respiratory and metabolic alkalosis. Okay. What is this? Yes, sodium potassium ATPase pump. So insulin is occurring and then it is making potassium inside the cell. Okay. Actually, you see treatment of diabetic ketoacidosis as well. I was telling you, overcorrection of hyperkalemia will also cause the same thing. Okay. Beta agonist like catecholamine, this one salbutamol, which we are using in asthmatic status asthmaticus patients. Diuretics, if you are giving furosemide and like loop diuretics without in chronic uses, if you are giving it without which medication? Which medication you should give with furosemide to avoid hypokalemia? Yes, please.
The aldactone, spironolactone,
Yes, spironolactone. Okay.
potassium sparing diet.
Yeah, spironolactone will cause a number of problems. It can cause, one of them is actually gynecomastia. Just like any other androgen, it can cause. Okay. So again, they have they have told about this periodic paralysis. So there may be arrhythmias, temperature dysregulation, and increased insulin. Okay, so this is a rare condition which occur familial periodic paralysis after any stress, after taking high carbohydrate meal, exercise, temperature extreme, and stress. Okay, so it is pushing potassium inside, and it will lead to all the features, but it will be a periodic thing. Okay, so that's why serial values will be important. Of course, you will be taking the history, and then you will be doing it. Pseudo hypokalemia, as I told you, the WBC is metabolic active, so they will put potassium inside the cell. Okay, so to prevent it, you can keep the blood sample chilled, and you can immediately centrifuge it. If you keep it for more time, there are chances both hypokalemia and hyperkalemia both can occur according to the scenario as I told you. If there is more hemolysis, there will be hyperkalemia. If it is more movement of sodium potassium ATPase, then it will be hypokalemia. Okay, so this may be an MCQ that how much is lost in stool, around 10 to 15 milligrams. Similarly, is lost in this one sweating. Okay, and kidneys according to the aldosterone and according to the flow of fluid in the lumen. If like diuretics, they are causing hypokalemia by other mechanism as well, which is only related to the flow. Okay, so if it is more flow, there will be more loss of potassium. Okay, so as I told you, this Bartter syndrome, hyperaldosteronism, they are just telling the same repetition, increased distal flow, increased mineral cortical activity, okay, and non-absorbable anions in the distal tubule. Okay. Aldosterone requires normal elevated flow in the distal nephrons to increase potassium excretion. Okay, as I told you, in volume depletion, decreased distal flow slows potassium excretion even in presence of aldosterone. Okay, so if there is low flow, there will be less effect of aldosterone as compared to if it is more flow. Bartter syndrome, as I told you, it is on the thick ascending limb of loop of Henle, and it is on the distal convoluted tubule. So it looks like thiazide and loop diuretics. Okay. This may be coming in the MCQ. So they are just explaining each and every aspect. How usually anyone can tell any question which is being asked, because for this you should be knowing about aldosterone, you should be knowing about how these different conditions can cause, because it will be just this one, just a repetition of things, and it is just correlation. Okay, so as we will go move forward in the electrolytes, you will find like the next bulk of magnesium, phosphate, calcium, vitamin D, calcitonin, parathyroid hormone. So these are all to be studied together if you want to understand the whole of the bone metabolism and the problems related to calcium, magnesium, phosphate. These are all interlinked through the hormones, parathormone, calcitonin, and the role of vitamin D. Okay, and what happens in liver failure and renal failure. So similarly is like that. Okay. So I think this is all repetition. So any questions before we finish? Any comment, anything? Yes, Mausama.
Sir, can you repeat that excitability due to tissues due to hypokalemia, action for resting, action?
Yes, you tell me one thing, which is where potassium is more, inside or outside?
Inside cell.
Okay, so there is a gradient which is there between inside ICF to ECF. Then when there is hypokalemia, this gradient is even increased. Okay, so during repolarization, more potassium is going out. So it may result in hyperpolarization. So when there is hyperpolarization, more heavy, like a more strong stimulus will be needed to get the excitation. So that's why, and the opposite effect will occur in the excitable tissues. There's the action potential there in the excitable SA node and the Purkinje fibers. So there it is causing arrhythmias. Okay, and it may increase the heart rate through conduction problems. Okay, clear, Mausama?
Yes, sir.
That's why you should be revising the action potential whenever you are reading anything like that. Okay, so if you want to read out, you can read the adrenals together. If you want to understand, again I repeat that you should be knowing, you cannot understand separately, you have to correlate these problems, these things. Okay, so I think we will stop here, and we will try to start the rest of the Pandora's box, because that is another Pandora's box we have to open. Okay, so thanks everyone, especially Sir Akhtar Wahid Khan. Thanks a lot, sir. Dr. Dora, I hope you are happy, because it's been a big honor for me to have someone from Europe attending the class. Okay, and today Shalini maybe from India. There is no one from Africa today. Okay.
Hear me?
Yes, Dora, you like it or no?
Yes, today was much easier than yesterday.
Yeah, because the topic is easier. Because you remember one thing, my tongue works more when I am fluent. When I am reluctant, it means I don't know. when I am happy with the topic, I can speak extempore. If I have to try to cram and reproduce, it is difficult. Okay. So anyways, thanks a lot.
Yes, thank you.
Yes. Okay. Okay, everybody. Thank you. Assalamu alaikum. And today is a very lucky day, because the mic of Dr. Humaira does not buzz. So thank you, Dr. Humaira. I think you have done something to correct it. Okay. Okay. Thank you. Bye bye. Assalamu alaikum.
Thank you.
Yes, I actually, yes, you are, Dr. Humaira, you are correct. Because hypernatremia always create low GCS in me. So I apologize for that. It's very difficult to explain. Okay. I have requested to faculty, respected faculty, and maybe we will have someone from Europe or America or any part of world to join us for some sessions. Okay, I've been added to one of the group where I have found a number of people who are willing to help out, because unfortunately it's only matter of your like, you know, where there is a will, there is a way, believe me. Okay, so whenever you want to do something, you can do it. If you don't want to do something, you will never do it. Okay, so that's why I will request all of you to invite other people. It's not that I will get more likes and I will get more publicity, and it's not like that. Okay, it's just like that I want to spread the message. Okay, and I want to pull all my residents, all my junior, all my seniors, colleague, to come out of the world of books. This is 2022, and we should be studying from multiple sources, from review articles, from a number of sources, just in a topic oriented way rather than a book oriented way. Okay, so thanks a lot. Assalamu alaikum.